Nurses are at the top of the most trusted professional group of workers in the country, and we've been there at the top since 2011.
You would probably find that the most trusted status is not just in the US, but everywhere.
But are we the most appreciated? Is there a level of appreciation that nurses are not just serving the people, but we are leading healthcare and making sure that it's safe, high quality care for everyone? Why should we wait till people get sick to provide services? Shouldn't we be keeping folks out of hospital? Shouldn't we be keeping people healthy and living longer, more qualitative lives? Doesn't it cost the system more money if we wait till people get sick and then we try to intervene? Nurses have always been about that. And how can you talk about healing a person without healing the family and healing the community? It's all interconnected. Nurses have taken even more substantive leadership roles in saying it requires more than just the intervention at the point of illness.
Welcome to Analyzing Healthcare podcast, brought to you by Scale Community. Scale Community is a global healthcare-focused member network where healthcare leaders come to connect, learn, share ideas, and shape what's next in our evolving healthcare landscape. To take advantage of all that Scale Community has to offer, from expansive content to virtual and in-person events, to interactive peer networking opportunities, and more, check out Scale Community at www.scale-community.com. Membership options range from free to paid, so if you enjoy today's discussion, please take a moment to sign up for your preferred membership level.
Okay, welcome to the latest edition of Analyzing Healthcare, podcast sponsored by Scale. I am joined today by Beverly Malone. Beverly, nice to see you. Hello.
Nice to see you also.
For those who don't know, my esteemed guest is the CEO of the National League for Nursing, the former president of the American Nurses Association, former Deputy Assistant Secretary of the U.S. Department of Health, and I think the former president of the Royal College for Nursing in the United Kingdom, if I'm not mistaken. Does that sound right?
Well, it's called the General Secretary there, but it's basically the same thing.
General Secretary. Head of. So National League for Nursing, I did a little bit of research, 40,000 members, 1,200 academic nurse institutions. Royal College for Nursing, 500,000 members and a labor union in its own right. And the American Nurses Association, 400,000 paying members representing millions of RNs across the country. A unique experience leading and representing nurse communities, both here and overseas in the United Kingdom, spanning many decades. And I just can't wait to jump in and learn from your experience.
I'm looking forward to it also.
Okay, so let's start. Allow me to be a historian here and work backwards. I want to start with the American Nurse Association, ANA, where I believe you worked on a few key areas. One of them, managed care, patient bill of rights. And this was during the Clinton period. Another area of focus was unsafe staffing and mandatory overtime as it pertained to nurses. So workplace safety. And the third was nurses' role in policy decision-making and professional autonomy. So trying to integrate nurses into the decision-making room, making sure that their voices are heard. All three incredibly worthwhile, valuable endeavors for back then, 1996 to 2000. Talk to me with that background. Talk to me about what you're seeing today, Beverly, in terms of the nursing community here in the US. Has it come a long way? Is it more of the same? Is it transformed versus what it was back then in 1996, 2000? I can't help but notice as an outsider reading a newspaper that we still see nurse strikes. I think most recently here in New York City, several large systems experienced a nurse strike only a month or two ago. So it still feels like there's friction, and maybe that's permanent. Maybe that friction will always be there. But just talk to me about what's the same and what's changed here in the US.
Well, some things never change about nursing. We're always here for the patients that we work with and for. And we always look at it as there's at least these components of caring, integrity, diversity and inclusion, and excellence as part of who we are and what we do. The most recent Gallup poll has shown that nurses are at the top of the most trusted professional group of workers in the country. And we've been there at the top since 2011, when firefighters aced us out of the top, as they should have. And then we were back the next year. Nursing has this incredible opportunity and privilege of working within the inner circle, inner system of patients and their families and communities, and knowing what those needs are. That has not changed. I don't believe that will ever change. And I've worked internationally, and those values are the same worldwide. It's not like there's a nurse in Australia who feels that it's not important to deliver the care to not just the patient, but the family and the community. There's so much consistency across the world with our value system. And so I would say
I imagine the trust is also global, right? You'd probably find that one of the most trusted groups, professional groups anywhere. Yeah, I would say you would probably find that the most trusted status is not just in the US, but everywhere.
Yeah. Yeah. And of course, nurses are always then saying, yeah, we are, but are we the most appreciated? And does those people we serve out in the larger community, do they acknowledge, and the people that we work with in our hospitals, in our communities, who pay us and who provide benefits for us, for our families and others, is there a level of appreciation that nurses are not just serving the people, but we are leading healthcare and making sure that it's safe, high quality care for everyone? So there's that interplay there about, thank you very much that we're the most trusted, and is there an acknowledgement of the role that we play, and how can we make sure that that's evident? And so I think all of that plays out, and it's been playing out over the years, so that's not changed. But I think that the technology, even the Obamacare, giving more access to patient care for people, interventional care, preventive care. I mean, why should we wait till people get sick to provide services? Shouldn't we be keeping folks out of hospital? Shouldn't we be keeping people healthy and living longer, more qualitative lives? Doesn't it cost the system more money if we wait till people get sick and then we try to intervene? Nurses have always been about that. And how can you talk about healing a person without healing the family and healing the community? It's all interconnected. And maybe it's not family. Maybe it's just significant others or people that they work with. So it's been that kind of evolution where nurses have taken even more substantive leadership roles in saying it requires more than just the intervention at the point of illness.
I think that's a great point. Imagine that it's different types of tailwinds and headwinds that are impacting the value offering and the opportunities for nurses over the past 20 plus years. You've got the introduction of forms of care that didn't exist 30 years ago. Virtual care. Telemedicine existed, but virtual care did not exist. You've got sophisticated forms of patient monitoring that didn't exist 30 years ago. You've got payment programs like value-based care that didn't exist 30 years ago. And it turns out that all of those place great emphasis and value and demand for nurses, right? They're an integral part of those programs. You can't do a large value-based care program without nurse oversight, right? Can't run a large patient monitoring program without nurse oversight. And you certainly can't provide virtual care in large amounts. In niche amounts, certainly, but in large amounts without nurse participation. They become critical.
Yes.
It is interesting that home care has become a larger part of the US healthcare pie, right? It has actually substituted for on-site care, for acute nursing home settings. A lot of care has been moved into the home and continues to be moved into the home.
Yeah.
And that still feels like a good fit for nurse care. So it looks like a lot of tailwinds. Talk to me about some of the headwinds. Where have nurses seen the last 20 years become more difficult as opposed to less difficult in terms of meaningful demand, employment, compensation? Where have they seen pushback?
COVID was just a major pushback for everybody. I'm a nurse, and dedicated to healing and helping people live better lives. I mean, I'm also responsible for helping people leave this earth in the most precious way we possibly can, with as little discomfort, with doing everything we can to save them, but not harassing them as they leave, and making sure that the family is okay too. So we've always looked at it as a system of care, not just an individual care. But I have to say that COVID knocked us back. Seeing hearses lined up at the exit of a hospital, in emergency care areas, just hearse after hearse, that kind of loss of life impacted nursing in particular. We were there, not able to touch the patient, not able to work with the patient in the way that we would want to, and watching them leave this earth in numbers that we had never seen before. That's called a pandemic. So that I don't want to underestimate what that did to change the workforce, to change nurses. And it wasn't just nurses. I mean, it was all the healthcare workforce. It was all the people, but nursing felt the particular brunt of it, because we are always there between the patient and whatever the system is doing. We're always there between the patient and technology. That's our role. We are the caregivers. It's our hands on the patient. And when we couldn't even put our hands on the patient, it was very disruptive for us and very demoralizing. I think that's a big piece of it. The sadness that goes when you cannot do your job, when you cannot give the care that you have learned how to do, when you cannot save the lives that seems like a continuing flow of loss and loss and loss on top of loss. So that's what the pandemic did for nursing. And we're still shaken and recovering from it, I believe.
We went through a lot of inflation during that period. We've gone through a lot of new technology adoption, automation, and we've also played around with different staffing models over that same period of time. And inflation tends to drive experimentation because everybody panics, it's crisis, and crisis leads to experimentation and change because everyone runs out of money during inflation. So some of the experimentation that's gone on beyond automation is to permanent employment models versus 1099 employment models, temporary employment models, direct employment versus indirect reliance on third-party locums and traveling solutions, temporary large bulk purchases of staff, other experimentation, different licenses, license up, license down, RNs, NPs versus PAs versus all the way down to technicians, right? And maybe even avoiding nurses wherever possible. And different states are more rigid than others when it comes to what license is required to provide what form of care. Talk to me about those different trends. What have you seen? What does the nurse community feel frustrated about when it comes to different forms of work and licensure encroaching on spaces that they feel squarely belong with NPs?
I think that all nurses feel, and when I say all, that is not the real every one of us, 100%. It's pejorative how I say that. I mean that most nurses feel that there's plenty good room for other providers. I mean, there's enough healthcare issues around. And
there's enough healthcare to go around.
There's not enough healthcare to go around, but there are enough healthcare issues to go around for sure. That as long as we got people on this earth, there will be healthcare issues, and we do not address all of them. And the rural communities are an excellent example where there's just not enough of a workforce out there ready. And with the hospitals being jeopardized about whether they're going to exist or not, right? It means that care in rural areas is also under attack. And so it's not just the rural areas. It can be in the middle of a city where the care is under attack and where there are not enough nurses to provide the care. So this has been something that's very personal to every nurse that I know about not enough of us to do the work. And the different types of licensure, like the nurse practitioner, the data shows that our colleagues who are nurse practitioners give care at times equal to, if not better than, our general practitioners who are our physician colleagues. Or in a certain area, maybe oncology, that they're right there in the office with the oncologist who's a physician, but also providing a level of care that is necessary to round out the care. So we find ourselves in highly complementary roles, but also in highly leadership roles, where, for example, with the nurse anesthetist, that there's no one out in some communities except the nurse anesthetist who's giving anesthesia. There is none. It is that certified registered nurse anesthetist who is doing it. So we filled in the gap for healthcare. And I think that when the government says that by 2030, the nurse practitioners will be the third most sought after position job-wise, that it's about that. It's about that healthcare needs become even more dramatic. People are living longer. And as they live longer, I don't know about you, we're going to need healthcare. Even more so within those last 10 years of our lives or 20 years, or whatever it gets to be that time, nurses are going to be there and they're going to need that advanced nurse practitioner who is also able to prescribe medication, follow up on it, order this test and that test, but follow up with the patient in a very different way than any other provider. Understanding the family issue, it's not just that 20-minute intervention in the office. It's about how do we follow up and make sure that the family is included in this, that the community is included. So nurses are educated on a very different framework. That's a holistic framework of all of it. It's not, if I'm a psych mental health nurse myself, but when I go to work with patients, do I only think about the psychological piece? No, I'm thinking that if they've got a stomach ailment, it's affecting the psychological piece. So I need to make sure I pay attention to the ailment that's going on with their gastrointestinal system or that skin condition that they have. And how does that fit in with what they're eating and what they're drinking and who their family is? It's a holistic system of the person in the system in which they live and survive. That's the view of nursing that I particularly love as a psychiatric mental health nurse who wants to say, well, how do you feel about that?
I love that. There's a few themes there that I don't spend enough time thinking about, but that are really valuable. One is the supply offset, or the shortage of supply offset is systemic across all of healthcare in every country that we've examined. What I mean by that is there's a shortage of doctors everywhere. And so what do sovereign nation states do about it that are responsible for their own populace? They find supply elsewhere. And how do they do that? Technology, wherever possible, sure, but rarely good enough. Overseas staffing solutions, very common. I was reading recently that I think it was Sweden employs 50% of its domestic physicians from overseas. Nurses is another one, along with derivatives of nurses like CRNAs, right? So the nurse compensation for we don't have enough doctors is a systemic theme across the world and should be recognized as such. I want to ask you about the nursing community views regarding imported nurses from overseas, a net positive, a net negative, mixed. And I want to ask you about the nurse community's view of the hospital community. The hospital administrative community, the landscape of health systems, certainly over the last 20 years, consolidating the way that it has, less and less hospitals in fewer and fewer administrative hands, right? I think we have half the number of hospitals today we had 50 years ago, and we have twice the population. So I want to dig deeper into what that means for nurses, because I think it's actually a very interesting topic. But just, are these subjects that appear again and again, foreign imported nurses, A, and B, the hospital landscape and what it means for us? What's the latest thinking there?
Let me start with using my colleagues who are Filipino nurses coming into the country, because when I was president of ANA, I went over to Manila and met with a lot of the schools of nursing over there. And it was as if the schools knew that they were there to develop nurses to export them to the U.S. That was part, that those nurses who would come to the U.S., that part of their responsibility was send money back to the Philippines to take care of the families. So this was just the natural pathway. And we have had some of the most extraordinary Filipino nurses in terms of workforce who are leaders in nursing, who have made the incredible difference in staffing our hospitals and our institutions and providing incredibly excellent care. I'm so supportive of the Filipino Nurses Association of America and what they've been able to accomplish. When I was in England for about 6 years, there was this whole emphasis about what happens when countries like England and the United States go to a country and recruit those nurses in that country. An example was like a Caribbean country that had a small emergency room where England or Scotland or someone came in and got the nurse, but they don't want the new nurses. They want the ones who are well-developed nurses, who are highly skilled nurses. So it crashes the entire emergency room for that country, for that small.
We're raiding their resources.
Exactly. And so the question became one of how can we extract what is an opportunity? How do you say to people, you can't come? You're equipped, but you cannot come. There are nurses who say, I want to go to that country. And so the issue is, in my mind, is how do we build a system that rewards people for wanting to come, but also allows them to go back and give back to their country in terms of the health care that's needed there? How can we support nurses who want that experience of being in England or the US and develop that, but because of the system that we set up of supporting them, that they owe so much back to their country of origin? I believe that those kind of programs could be put in place that would be supportive of the country they're coming from, supportive of the US, and supportive of their return back to their country to give as they should.
What would be an example of that? Would it be, hey, we're offering hundreds, maybe thousands of scholarships we're offering scholarships to individuals in that example, in that Caribbean country, to
Yes.
come here and study nursing on our dime, and we'll send them back to your country as a way of saying thank you for supplying us with some of your most experienced nurses. Would
Yeah.
that be an example?
I believe there are bright enough people who could arrange a system of support, just like we do when we want nurses in a certain area of the country, right? I'm a psych nurse only because the government gave me money to become an advanced practice psych nurse. They paid for my last 2 years of my undergraduate degree, and they paid for my 2 years of my master's program. And I would never have been a psych nurse otherwise. I would have been a surgical nurse. I loved healing bones and wounds. So there needs to be an incentive, and there needs to be something in it for the country that they're coming from, and something in it for the US, and something to inspire them to return to their country. So I think that those kind of strategies are very important. The other thing that I would say is that you also wanted to know about the administrative.
Let's go back. I'm going to go back to hospitals because I think it's a really important topic, and I want to stay on this theme of education for a second, because I know over the last decade, at least, at the National League for Nursing, this has been your focus, the training of nurses, and I think it's a very rich topic. So I want to unpack it a little bit more. Is there a shortage of nursing schools in this country? I would guess the answer is probably yes.
Well,
is there a shortage of government funding to incentivize candidates to sign up for nursing education? I think most of us, the part of our mind that tries to act like economists, I don't give it the time it deserves to really think through these things, right? If there's a shortage of candidates and a shortage of schools and a shortage of graduates, there's probably a misalignment of government funding somewhere to try to facilitate all of that. And how does all of that reconcile with your experience?
It's funny that you asked, because right now we have something from the Department of Education that will put even more of a pressure on schools of nursing to hire faculty. And that is a reduction of the funds available for loans for nurses who are going into their master's or doctoral preparation, which are the nurses that we need to be educators of other nurses. So we already have a shortage of nurse educators. That has proven to be one of the main reasons we have a shortage of nurses. If you have a shortage of nurse educators, voila, you then have a shortage of nurses. So that's been happening. And you say, well, why, Bev, has it been happening? One of the reasons is the funding of grants and scholarships and loans. And like I said, the Department of Education is right now just trying to issue a ruling that will actually decrease the amount from $200,000 to $100,000 being the maximal amount that nurses can get in terms of their advanced education. And basically saying they're not part of the professional group that is exempt from this cut. My understanding, this was all part of the big, beautiful bill. So I'm very concerned about that. And I think
Yeah.
we're biting off our nose to spite our face on this one.
This is the funny thing, right? Is that we're all supposed to believe in market principles, and to some extent we should. And yet you could take average nurse pay and increase it from $90,000 in the US to $300,000. Absolutely nothing would change if what we're left with is the same amount of nursing schools charging the same amount of tuition fees with the same amount of loans. And, the ask of a young candidate is borrow hundreds of thousands of dollars in the hope that maybe eventually you'll make 300,000. Maybe something would change. Maybe more candidates would sign up because the return is greater. But at the end of the day, more candidates doesn't mean more graduates if the schools are only offering the same number of classes or seats in classes. And how does offering a nurse $300,000 versus $90,000 help a school? And so you have to solve for all these pieces in the puzzle and not just assume that wages alone drive outcome, because there are major bottlenecks. And we see that in the physician space as well, right? Agencies create a bottleneck, and physician income can increase substantially, and that bottleneck remains.
Well, one of the things that nurses tend to do is to get a degree, like their first degree, baccalaureate in nursing, then they work a while. And then they get the next degree, and then they work a while, and then they get the next degree. So having funding for that means that they usually come out very highly skilled, and then the knowledge on top of that in terms of skills. So we become these incredibly valuable products to not only provide healthcare, but to lead healthcare and to teach. The shortage is clearly the results of two things. This shortage that has occurred over the years. One of them is not enough nurse educators, and the second is not enough clinical placements for students to learn and grow because there's such competition. So all of that is happening. And I'm of the opinion that unless we make sure that nurse educators are given the same opportunities that others in university settings are paid well, because nursing schools don't tend to pay as well as some of the other schools. We have a lot of clinical practice, like law, where there's these opportunities of practice, where medicine, where there's but we don't have the same funding available as our other colleagues for it. So it means that nurse faculty are often paid much less than other provider groups.
Well, that's an important point.
That's a huge issue. For why would a young nurse or even an older nurse choose to become an educator when someone who graduates from their program can make as much money clinically as they're making teaching? So we've got to work on that piece about making sure that faculty are appropriately paid for their work in their universities in context, in comparison with the other groups that are there. The other piece I want to mention is we're frequently the cash cow of the organization, because the first years are science and social science and literature, and it's not just nursing. So we give so much to the university in terms of opportunities for science degrees and other types of programs, social science, for the money to be going to the university, not into the nursing pocket. All of those are major issues for the nursing schools.
Firstly, there's some huge points there. Unpacking the economics is what I would call it. Economics is I think, the worst subject in the world. It's where I spend most of my time, because nothing lends itself to bias better than economics. You think you know because you have one or two numbers or facts presented to you here or there in an article, but you don't know. And I'll give you a perfect example. I've lived under the assumption that nurses are incredibly inflationary here in the US. They're always striking, they're always negotiating, they're always unionizing. And I know that hospitals are incredibly inflationary. That I know. That they've increased to 10% as a group, not all hospitals. So even that, you've got to be careful, right? Regional, community, publicly funded, privately funded, different types of hospitals with different economics, Medicaid focused, commercial payer focused. But I know that as a group, hospitals have increased their prices at a rate of about 10% per year for the last 20 years, which is incredibly inflationary. And I also know nurses. I used to employ a lot of nurses, and I used to have to pay them a lot of money. So, especially in New York, where we were based at the time. So I always assumed that hospital nurses are somewhere between $100,000 and $200,000 of annual salary. So in my mind, uninformed mind, hospitals are inflationary, nurses are inflationary, and their pay is probably increasing at a similar rate. Here's where doing a little bit of research helps. So average nurse pay is not $150,000, it's $85,000. There are nurses that make $150,000, but they're the anomaly, right? They're on the high end and they're working at very expensive hospitals in very expensive locations, and they're not the norm. Here's where it gets particularly interesting. Nurse pay has increased in line with inflation over the last 20 years, 65%. Hospital pay or hospital fees have increased at 3 times that rate. So the same nurses that have worked in hospitals have seen their pay relative to other hospital expenses actually decrease. Whereas other hospital expenses are going up, whether it's the physician side, whether it's research, administration, drugs, capex, buildings, locums, whatever you want to call it. It hasn't been the nurses. And I think that's really interesting. I'll give you another interesting economic fact that gets thrown around. US nurses, well, they get paid a lot more than every other nurse. UK nurses are at $50,000, 35,000 pounds. US nurses, even adjusted for reality, are at $95,000. So nurses must be doing great. I'm interested in your thought on that last point, because I think just because someone overseas is getting paid less than you doesn't mean you're doing great. And it certainly doesn't mean that you're the source of inflation in your country. So there's a lot there in that question. Like,
There's a lot.
I think nurses get assumed of being inflationary unfairly, because I think I didn't do this research until recently. How many people are really digging in to see what's actually happening inside these hospitals? What are your thoughts?
Well, I want to support your research, for one thing, and to say that you're right on target, that we are not inflationary. We're not the ones driving up the cost of hospital care, and that frequently we're the ones bringing it down in terms of taking care of patients night and day, 24 hours a day. I don't think there are very few other groups that are around the clock the way nurses are.
Yeah.
And that's what we do, and that's what we've been doing, and we understand that, and that we know that we give value that way. The person in England who's making 50,000, perhaps equivalent 35,000, according to their pay schedule, versus the 50,000 when you convert it to money in the US. They're I believe they need increased pay also. And if you check you'll find that while their system of care is going up higher, nurses' salary are still being sat on by the system, and that they're having difficulty with that and raising their voices and saying, how can we continue to provide the service that is needed to be provided when we cannot afford to take care of our own families because of the pay level that we're being paid at? So I don't think this is just a U.S. issue. I think it is
No,
a
I mean,
world I
I
think
don't
it's a
think the answer,
worldwide
I don't think
issue
the
about
answer,
nursing. And I
yeah,
can't help but say that somehow it's connected to being a predominantly female group of people.
I wanted
And
to
that
touch on that.
somehow we shouldn't want more than what we should be happy with whatever you
Yeah.
give us. Aren't you just happy to be able to get out of your house and take care and work outside of raising your children and whatever else we have you do as women? And yet nurses are doing both. It's not that we are either working or not taking care of our children. We are doing both. We're doing it all. And we are still not being reimbursed in the way that we should. So when I say that nurse educators need to be reimbursed more, it doesn't exclude that nurses, whether it's in hospital or communities, need to be reimbursed more. We need to stay up with the economy that we're in, and whatever economy that is, whether it's the British system of the NHS or whether it's the US that I can't really call a system of care. It's true that we need to be relevant, and in some way, the care that we're giving needs to be appreciated by dollars. I don't just want you to say, oh, how wonderful nursing is. I want to see the dollars that match what you say with the care that we're providing, the service that we're providing, the value-based care we're providing.
So I just want to go to a picket line right now. Let's go. You and me.
Been to picket lines before in another life when I was
Me too.
president of the
I've
American
marched on a
Nurses
nurse picket
Association.
line.
And the funny thing about that is I went to Alaska and they were picketing, right? And the docs were picketing with the nurses outside the hospital. But the funny piece is that they told me I was turning blue because I didn't have a good coat on and it was Alaska. And so they were dressed in shorts and bathing suits and I was freezing. So there is a difference, even in the United States of America, as we go from one place to the other. But the basic issue of not being appreciated and valued by the dollar is there for all nurses.
You know, North in America is an interesting term because it just keeps going. There's a lot in what you said, and I am being sincere. I agree with all of it. I don't think the answer to $90,000 pay, average pay in the US, $50,000 average pay in the UK is, well, why don't we pay all of our nurses here $50,000? I don't think that's the answer.
No.
When I think about £40,000 for a nurse putting in an 8 to 10 hour shift starting at midnight, I can't believe that they're getting away with that. I think that's bloody murder.
Yeah.
And I do think a few things, questions and comments. I was going to ask you because there's over 5 million nurses here in the US. If you include derivatives of nurses, there's 4.5 million registered nurses, and then you add all the other forms. You get to over 5 million, 5.5 million paid nurses. Over 90, I think it's as much as 95% of them are female. And I do wonder what that means. If I had to look at something else analogous to it from an economics lens, I'd probably pick education, but I don't think you can come anywhere near that 95% number. I think it is unique, right, on that scale. And I just wonder to what extent you bring it up, you think that there is an exploitation factor there. And my question is, sure, but nurses have been around in America for 250 years, right? As long as there's been America, there's probably been a nurse.
That's right.
The early settlers came with wives. I'm sure some of the wives volunteered for nursing roles.
And some of the men.
I imagine 5% of the men back then volunteered too. So there's been this gender issue for 250 years, and there's been unionization. Why isn't unionization good enough to get the job done here and elsewhere, right? The power of strike, the power of labor, the power of coordinated negotiation. You would think that a head of a union, you formerly being one in the UK, would say, £40,000, no good, 45 or else. I'm oversimplifying. I've never run a union before. Why isn't the power of the union strong enough to apply that kind of leverage and get that kind of outcome?
Healthcare leaders, if your revenue cycle management is underwhelming you, it's time to rethink your current suite of solutions. Scale Healthcare's AI-powered RCM solutions are purpose-built to protect and accelerate revenue across the entire lifecycle. Denial Shield proactively prevents denials before claims ever go out, using agentic AI to automate root cause detection and resolution. Front Desk Shield streamlines preclinical and front-end workflows, eligibility, authorization, and intake, reducing friction before revenue is even created. And Revenue Shield maximizes charge capture and revenue integrity, ensuring nothing slips through the cracks. Together, the Shield suite helps organizations reduce operating costs, capture missed revenue, accelerate cash flow, and increase productivity without ripping and replacing existing systems. If you're ready for immediate ROI and measurable impact, visit scalehealthcare.com and see how the Shield suite is redefining AI-powered RCM.
Well, when you say or else, there is no nurse who wants to strike and see patients suffer.
Good point.
Maybe we have one aberrant one somewhere, but it is not the majority of us that. And so you deal with that about most nurses don't want to go on strike. They don't want to walk away from their patients. We are educated and prepared to take care of people. Like I said, from birth to death, from cradle to grave. That's who we are. And so the idea of walking away from our patients is not something we take lightly. And usually nurses are pushed, crushed to the floor before they will do that they will get to a point where they can see that they're not even able to provide the care unless something changes. So you will find that there will be rumors of a strike, rumors of this situation in this place or that place, and that they don't move on it until it's like, no more. We can
And
take
it is interesting. These strikes are very short. I can't think anecdotally of very long, drawn out nurse strikes.
And frequently somebody's trying to figure out, how do we get nurses in there to patient care to make sure that no patients suffer? It's who we are. I mean, how can I say on one hand that we are the most trusted professional group in these United States, and not at the same time say about caring and integrity that we have about the people that we serve?
A very good point.
So that's who we are.
Okay, so you're appealing to your given economy's better nature, and we're seeing the results. There's a gap. There's some interesting pay gaps that
That's right.
could use some work.
There was
Let's
one
put it that way.
time that I was a faculty member at a university where the provost came in and said, you nursing faculty should be happy with what you have. The rest of the university is going to get an increase, but we know you love to do the work you do.
Oh, my word.
I mean, it's that kind of mentality that will drive you insane, where folks are just showing that they have no respect for the work that you do, for the service that you provide.
It's almost like an example of what you're warned sometimes against by the cynics out there, and I tend to reject it, but it is a living, breathing example of being nice doesn't always mean you finish first. So that is interesting.
It's reprehensible. It's such disrespect, such disregard.
Yeah.
That it goes beyond the imagination. The other thing that I need to say is that nursing has a larger percentage of men who are in nursing, who are wonderful nurses, who provide incredible care than ever before. And with some of them, they are raising the bar in terms of some of the issues also. And of course, being dealt in a little bit different way at times. And in
That's
England, I
interesting,
know
too.
that was an issue too. And that if you look at some of the organizations globally, you will find nurses are mostly male dominated in terms of leadership. I always think that's a very interesting commentary for the US.
That is interesting. If 5% of your workforce is male and yet they're representing you, what does that say about our society?
That's right. That's right. But but there's some incredibly gifted male nurses. No doubt about it. The American Nurses Association had its first male nurse just about 4 years ago. In all of the years, 130 years or something, the first male nurse. So it's different in different countries. It has to do with your background, your culture, all the things that went into it. But I can tell you that the the mission of every nurse is to provide care for everyone. And that means we provide care for people who are different in this way, different in that way. But my job is to make sure that everybody gets care.
There's a lot of behavioral economics insight here, which more than usual because of the strange ingredients that exist, right? It is really a case study that we should all spend more time on to learn about ourselves, frankly. So I really appreciate it. I want to end on a positive note. Okay, let's end with a smile. What is the 5 million plus nurse community in the US most excited about over the next, call it 12 to 60 months? So a year to five years. What are they looking forward to that they just can't wait till it unfolds? Is it we want that latest AI tool that's going to make our life a lot easier? Well, which AI tool? Is it some kind of government regulation that's on the cusp of being approved? And as soon as it is, things will get much better. What is it that is the upside rosy case, silver lining that nurses speak about and gets them excited?
For me, speaking as a nurse who has had the opportunity to serve at different levels of the organization, it has to do with that nurses are just totally brilliant and they continue to develop and grow, and that we're going to keep moving in that direction, providing care to more people. Licenses are going to we have compacts where you can get a license in 4 states Huh? And so how do we do that all over the country so that nurses can move freely and provide services all across the United States? The same, get one license and boom, you can do care everywhere. I think that's in the pot and that's going to go. I think the continued development of nurse researchers who are researching not just, you see, research has always been about these blind studies of this medication or that, but nurses say, how do you take the medication? What kind of symptoms do you have? How are you feeling? How do you work with your family? We are about that research that says, if you implement this, what are the results of it? And how's your life better? What do you need? And that kind of living research is what nursing is about. So I see that as something of an opportunity. I see the opportunity to make a difference to children and to our immigrant population, to the folks who are here, to those who are working to just be working every day of their lives. How can we make their lives better? And to me, one of the most exciting things going on is prevention. I'm understanding they're doing research now that where they can tell you which part of your brain is not doing as well early on in your life, so you'll know whether or not you need to take some steps to prevent dementia. I think those kinds of issues nursing will be taking on about how do we not just take care of people after they get sick, but how do we take care of them how can we prevent them from getting sick? And I'm so excited about that the more we can do to keep the world healthy, to keep the U.S. healthy, that's what we'll be doing. And nurses will be leading hospitals. You'll find more nurse executives who are chief executive officers. Nursing will be leading other institutions. You will find more nurses. All of that is out there for us. And I am truly excited about it.
That sounds awesome. I like the mobile license. State agnostic. I think that's very cool. Is that in the works? Is that a regulation that's being reviewed, being proposed by anyone? Or is that still in concept stage?
I'm sorry, your voice went down.
You said the license that travels across state
Right.
lines.
It's already happening. We've got compacts of like 4 and 5 states, but I know that the National Council of State Boards of Nursing, I know the goal is to spread it as far as we can, because there shouldn't be any limits, state limits about whether you can practice. Yeah. We need to be held accountable for our practice. But if we have these compacts, if we have where states understand and they talk to each other, and we have the technology to do it. I can sit here in Virginia and talk to someone in California. I'm a psych nurse. I can talk to them about their psychological issues. We need that kind of licensing going on, and that's happening. So I'm very excited about it.
If you need me to march for that, I'll march for that too. That's another item you can add to my picket list. I'll leave you with one interesting idea, which I think is worth getting excited about. Today, 58% of nurses are employed by hospitals. I think that number is going to go down. And I think what's going to, and that's fine. I don't have anything against hospitals. There's a lot good happening there, and I understand it. It's all good. But I do think it's nice to have choices. And I do think that when you talk about preventative care, a lot of that is not going to be provided by hospitals, nor should it be. It's not where they excel. But when you think about the new entrants, the actors who are leading the preventative care charge, businesses that excel in technology, businesses that excel in coordination, in data management, in B2C products, business to consumer, so consumer-based businesses, right? And I do think that every time these businesses, let's use Apple as an example. Every time Apple marches into healthcare, the assumption is that they're going to march in with nothing but technology in their tool bag and software engineers and maybe a few marketing experts to boot. I don't think that's how it works. I think for every one of these companies that brings preventative care solutions, modern alternative forms of primary care, preventative care, longevity care into the marketplace, invariably, there's probably roles for nurses.
Oh, yeah.
And the larger these companies get, we saw this with value-based care, right? I spent time with Oscar. Oscar employs a lot of nurses. It's a large payer that functions on the Obama exchange, right? ACA. They employ a lot of nurses. Every time these companies grow and they scale, the successful ones, there's going to be a growing body of nurses that they rely on to facilitate patient care and provided in a generalist form, I do think the nurses represent generalist care, which is a really strong body of care. We can talk about acute specialists all day long, but they don't substitute for the generalists. They complement the generalists. So I think that's something that I would be very excited about for the nurse community.
I'm very excited about that too. I always say that, no, I don't always say this. I heard somebody else say it, that technology, AI, will do hands-off care so nurses can do more hands-on care.
I love that. That's whoever said that. Tell them I like that. That's nice.
Yeah. I think it's perfect because it stays with what I began our conversation with, our commitment to care, being there between the patient and technology. We will always be there between whatever the new thing is and the patient. That's who we are. We are there with the hands on the patient. Yes.
We're going to end on that note, Beverly. You're an inspiration. And I'm so grateful to the nursing community that they've had you to speak on their behalf for all this time. And I'm also grateful that you spent a little bit of your time with me today. Thank you.
Honored to be here. My pleasure.
Thank you for joining us on Analyzing Healthcare. Stay informed and stay inspired. Don't forget to subscribe and visit scale-community.com to become a Scale Community member. Until next time, keep exploring the ideas that shape our healthcare systems.